Alisha, Moopen, she's director from Aster Healthcare Dubai. She'll be talking about building a medical city with a focus on medical value travel, which is maybe another term for medical tourism. And she'll be talking about a new project which is happening in India. So let's welcome Ms. Alisha Moopen.
Hi, thank you so much. I'm really happy to be here in front of so many leaders of the medical community. I'm hoping everyone is a little bit fed and watered and in a happier mood right now. So I want to start by saying probably something slightly controversial. I don't believe that the world needs another smartphone. I don't think we need another bigger computer or I don't know, another magic pill. I think what we really need is a mechanism that will help us deliver things that we have already developed to people who deserve it. And by that I mean in healthcare. I think we have already come up with good systems, good processes, good treatment plans. And what we really need to be focusing on, how we can get these solutions to people who need it. Where at this point, I think the majority of the population don't have access to what has already been developed. So this is where my topic of medical value travel comes in. The main crux of this it lies on this. It is basically people traveling to other parts for better value, because it's become so exorbitant in so many parts of the world to sort of cater for basic healthcare needs that they have to look outside for it. Just to give a brief introduction about Aster Healthcare. So this is a homegrown brand. We started here in 1987 as a single practitioner clinic, and now we have over 200 facilities across GCC and in India. And we started with primary, moved on to secondary and tertiary, and now we've just commissioned our quaternary care medical city in India, which I'll talk to you about later. Just to give a brief introduction about the medical value, the health tourism industry overall. It said in 2012 probably around 7 million people traveled, and the estimated industry is around $10 to $25 billion excluding travel costs. In India itself, if I focus on it, in 2002 we had 150,000 patients traveling, which moved up by 2012 to 1.1 million people who traveled to India for medical tourism, crossing over 2 billion in healthcare. So you see an increase of 25–30% annually, which is humongous. MVT in South Asia primarily started with the focus being on Singapore and Thailand, but now you see a lot of shift also moving towards India, for obvious reasons, which I'll discuss soon. Now, if I talk about South Asia, which is the sort of 7–8 countries around India, so you have India, Pakistan, Bangladesh, Maldives, Sri Lanka, Afghanistan, Myanmar. We have a salad bowl of culture, very similar kind of cultural identities, and as a result of it, you will see that we all share very similar and common health issues as well. So South Asia, we're talking about the countries which constitute about 1.7 billion people. So that's around 17–18% of the world's population. But even though it has only got 17% of the world's population, we actually bear 60% of the world's disease burden. Now that's really alarming, and that is something that we really need to be worried and thinking about. Now the capital of South Asia will be India with the 1.2 billion people. Now, to touch upon some of the key trends in healthcare in India, you see a large shift of the disease profile, moving from the communicable diseases to the non-communicable diseases. With the increasing proliferation of the urban conglomerates, I think and with a very aspiring society that India has and Asia has, there's a lot of glamour for the elements of the West. So be it going for your burgers or your pizzas or the smoking and drinking. So there's a lot of adoption of these sort of things, which has really increased sort of the lifestyle diseases in our country. You see, another thing which is quite pertinent now in India is the requirement for the increasing penetration of health insurance. Right now, about 70% of all hospital bills are out of pocket. Now that actually is a really worrying sum. So we've actually had families, not just a few case studies. You hear dozens and hundreds and thousands of people who actually move from being in a steady economic level, moving down under the poverty line because of acute illness. Because there is no safety net. They haven't got the insurance. So people selling farms, people selling their houses just to be able to cater to these health requirements, acute illnesses that come up. And so there obviously is, there will be an increasing penetration you'll see coming forward, and of course there's an opportunity for healthcare industry. Medical value travel. Now, as I touched upon earlier as well, there is a huge, India is occupying a huge space as far as this medical value travel is concerned. As I mentioned earlier, we had almost 2 billion receipts in 2012, and you will see similarly the other South Asian countries also have been receiving some level of patients coming across. Even to that extent, you see there is some activity happening in like Afghanistan, so there is something obviously that people are going there as well for. So just to touch upon what are the reasons why are people traveling to India for that? Of course, you know, what you want is good quality healthcare at good, affordable or reasonable cost. Now what's reasonable is very relative, but what is the reason? Why is it low cost? Basically with a population base of 1.2 billion and a young population, the median age in India is actually 25. So you have a surplus of working population. So the supply of labor makes sort of that cost much low for us to sort of run a healthcare service. When you look at the spend of healthcare in the West, so for example in the US, around 15 to 17% of GDP is spent in the US. Now when you look at it at a granular level, the main cost that amounts there is actually your manpower costs and admin costs, and those are very expensive, and those costs are in turn sort of borne by the end user or the payers. Lesser waiting times, that there is a requirement to wait, or there is a bottleneck over there with the pipeline of patients that are going in. So that waiting time is a lot less when you are coming to the South Asian countries, especially with in the private healthcare. World-class quality. Now this is something that you know, will never be compromised on, and you'll see the large number of increasing accredited hospitals, both JCI and NABH. In India, we have around 240 NABH hospitals and around approximately 20 JCI accredited facilities in India. We also have this Henry Ford of cardiology, Dr. Shetty in India, who has managed to sort of do heart surgeries for as low as $800. Now that's almost like a factory that it runs. He has a huge facility with around 60 operating rooms, doing around 300 open heart surgeries in a month. And really, so you are getting good quality and you're getting sort of the lowest cost. Now that is what we want to aim for the world to be able to get to, where everyone has access to that. Not that they have to spend $50,000 for a procedure, which somewhere in the world people are doing for as low as $800. Personalized service, again, this is an outcome of the low cost of labor. You are able to give the personalized service. You are able to have a lot of people involved in sort of that service quality, the hospitality industry that we so boast about in Dubai and in the GCC. You can give those sort of services to the people who come abroad. The cultural destination, so India is the heritage, the legacies, all that comes with it, the charm that comes with it. I think that is an attraction to people, and there is a lot to explore, there's a lot to learn, and that obviously provides some sort of added advantage or attraction for India. Language is also key when you sort of decide on where you want to go. So most of the people in India are, there are a lot of people who are English speaking. Most of the hospitals are sort of staffed accordingly, especially those that are looking for tourists, foreign travelers. Connectivity becomes a key issue, so you do want a facility which is accessible, not just physical accessibility, but also financial accessibility, like affordability that I mentioned earlier. Just some comparisons of the cost between the West and then comparing it to India. So here you have angioplasties which are being done for $57,000 in the US, and then which in India actually you're doing it as low as $5,000. And then you talk about a knee replacement, which in the US costs you around $40,000, which in India is roughly about $2,400. Now these are the average ranges that I'm talking about in India, and there are centers which are doing much less than that as well. The main tourists who come to India are mainly from the SAARC countries, so they are from the Bangladesh, Maldives, Afghanistan. Recently, with the economic downturn, we are seeing increasing number of patients coming from Russia, Europe, and the US. Other than coming for modern medicine, we also have large interest in people coming, especially from Germany and France. I think in 2012 we had around 350,000 people who came to India for Ayurvedic, which is a 5,000-year-old school of medicine that has, which actually gets excellent results for some medical conditions. Primarily, you'll see for dermatology, musculoskeletal issues. So that is also something which is very popular, alternative medicine, and the costs are much lower as well. The main departments or the areas that India is sought after for is cardiac, then orthopedic, nephrology, and oncology. I think that is very similar. You will see the same pattern in other countries also that receives it, because this is the main disease burden. So that, you know, with your diabetes, with your coronary artery diseases, I mean, these are the main departments which will always come at the top of these lists. So when you look at the savings of people when you're traveling to the South Asian countries compared to the West, you can see an average saving of 65 to 90% compared to the US cost. Now that is huge. People say they can actually pay with a credit card what instead they have to sort of mortgage their home to pay for. So that goes a long way for people when they're making their decisions. As I mentioned before, the number of, being a quality leader, the number of JCI accredited facilities is very high in India. You have around 19 facilities already. Some of the challenges to MET in the Middle East, in the subcontinent, sorry. There is obviously a little bit of worry when you are traveling to a new country, especially when you're talking about coming from the West as such, and that you have to be open, you have to understand that you have to go through sort of the cultural challenges about moving to a new city or going up and exploring that. But I think with the advent of internet and sort of everything getting so connected, people are able to sort of prepare themselves and come ready to explore, and also sort of understand the requirements and how you need to behave when you are at a new place. So it is all just about sort of that knowledge and awareness that really matters. Connectivity to doctors. Now, at a pre-procedure stage, before you are going to a country, and at the procedure stage, I think most of the countries do tend to keep the patients quite happy and connected, and sort of that information sharing happens very seamlessly. But at the post-procedure, when the patient is finished with the procedure and the procedure goes well, and they go back to the home country, the connectivity to the doctor or the or to the facility and sort of follow-ups become a slightly bit more of an issue. It is a challenge wherever you go, because your referring doctor or your doctor back home might not actually want to take on the risk of sort of dealing with a patient who hasn't had the treatment in the home country itself. But there are a lot of ways you can mitigate those sort of challenges. Same thing with legal issues and financial issues around any claims post-operation. I'd like to just sort of introduce our new facility. So I think my co-speaker from InterHealth, he actually spoke about how medical cities sort of evolve depending on the requirements of the community and other factors that sort of contribute to it. Now, I think similarly like in Dubai, one project that we have created in India is something where you have strategically planned this in advance. So our MedCity, it really sort of is built after studying sort of the models of the Mayo Clinic, the Cleveland Clinic, our local examples like the Apollo Health City and the Medanta in Delhi. So these are all ones that we have studied heavily, where we've taken sort of the best in terms of the system of care and the clinical outcomes that it sort of boasts of. We wanted to sort of merge that along with the with sort of better pricing, better sort of ambiance, and sort of give something truly world-class back to India, and we are really a crown jewel there. So like I said, that is the main concept for MedCity. So what are the pillars for a medical city? What do you need? You need it to be state-of-the-art, of course. It has to be fully loaded in terms of technology. It has to be world-class. What we've done here, we've had the fusion of different treatment modalities, like I said, be it Ayurvedic or Unani and homeopathy. We've tried to sort of have a fusion of these different modalities. This gives options to our patients, and it also helps in bringing down the cost. See, I don't need the most beautiful facility, and it's not only just about having the best equipment. At the end of it, it is your team of doctors, and it is the system of care that makes the difference. So we have hand-picked doctors, not rock stars, wonderful doctors who are team players, who believe in the team-based practice of medicine. And to do that, you actually, to attract those sort of high-end doctors, you do need to provide them with an ecosystem of teaching, academics, research, and that is what we have tried to incorporate. And that is usually the pillar of medical city that we've been all talking about. You want that concentration of specialization. Only when you have that concentration of specialization will you get better outcomes. That's the only way you can either reduce your cost and increase your quality, because what happens is you have your experts coming in, you have, with the volumes that drive in, that helps in recognizing sort of symptoms earlier, you are able to diagnose things better. So early intervention of any sort of healthcare problems means early intervention will reduce your cost and get better results earlier rather than increasing that to a level where you have to go in at a much higher level of intervention. So that level of growth and the academics all sort of contribute to that learning environment, which really is what we need to be focusing on. So like I said, this medical city is really an umbrella of having all these things kind of seamlessly put together in a synergized way. Now that's my new facility that I was talking to you about. So we've got, it's a 1,000-bed facility in 2 phases. In the first phase, we have close to 600 beds, and we'll be commissioning the remaining beds in 3 or 4 years. So you have 575 beds coming up right now. It's on the waterfront. You've got 1 kilometer of waterfront, over 40 acres of land. It's 3.2 million square feet, with 1.2 million being built in the first phase. So where else can you go where it's almost like going to a resort? You go there and it's really like being on a holiday. So yes, if people want to go there, you want to make it a holiday with your family, then nothing like that. Now just when we are talking about building a medical city, it is to serve primarily the community around it. So to give a brief background on where it is in Kerala, which is one of the southern states of India, and it's got a population of 33 million. The city where the hospital is situated is in Kochi, which has a population of around 2 million. So in Kerala itself, with this 30 million, you have people with diabetes are around 7 million of that. That's a huge percentage. So you do realize sort of the disease burden that is being carried by the people. So to serve that population and to sort of build for the community that we are in was our primary sort of goal. That's the same thing that I was just discussing right now. So it's not just a hospital. It is, you have the few elements that are there. It's a multi-specialty hospital, and then you have the 9 centers of excellence. Now, centers of excellence doesn't mean just the name board of the different departments. There are literally 9 hospitals plugged into the main hospital. So if you go into our orthopedic department, you will have somebody you'll have your consultant for your hips, your knees, your ankle, your wrist, sports medicine. You will have pediatric orthopedics, you have ortho-oncology. So it's a complete 360-degree care that you're talking about in each of the centers of excellence. You will have a medical imaging in each of the different centers of excellence. So you have, they're all sort of split out from the main hospital. So you don't have to go to the main hospital if all you're going to do is meet an orthopedic doctor. So you can actually just go to a different set where only your problem, you'll only have to deal with the orthopedic cases. So in terms of the hospital, there is a little bit of decentralization. So you obviously have the main medical imaging, which is there, but we wanted to make it comprehensive in each center of excellence. So like I said, it is like an individual hospital in each case amongst the centers of excellence. It's got a medical township, so it's got a township of around 10,000 people. We expect there to be around a 500-seat convention center apart from the hospital, and a hotel and other residential villas. A brief history about the land that we're building in. It actually used to be 40 acres of wasteland. It used to be a municipal dump yard, and then in 1970s, and if you see now what it is, it's completely transformed to this iconic facility there. We have actually ended up hiring approximately 18% of the people from the local community. It is really about giving back to the society you are in. So other than hiring from the community and sort of serving their healthcare needs, we've also adopted sort of around 20-25,000 families, which constitutes all the families under the poverty line in our village, and sort of promised both OP and IP service for any of their requirements. Like I said, as a design philosophy, we have tried to look very holistically, looking at all the branches. Like I said, it is much better you plan in advance. If you plan in advance, you can save a lot of time later on where you're not trying to sort of add on. There's always the challenge, you'll have doctors coming in, you'll have clinicians. We've got a great team that has come in from the Great Ormond Street in London, the whole pediatric team that has come in. They come and there are requirements, so they're always that push and pull. What can we give at this point? What can be phased out? So you want your clinicians to be happy, you want it to be the best care that can reach at the end to your patients. So right from the beginning, we have tried to include all the stakeholders and make sure that everyone's inputs are taken into place, because it's better to plan in advance than have to make rectifications later on. Just a little bit more on the design philosophy. So I come from God's own country, which is Kerala. So we've tried to take elements from our state and use that for the design elements of this facility. So you have the light. Kerala is quite interesting because you have beaches, you have mountains, you have and so we've got this tea estate here that's in Kerala actually, which is very popular, like you hear about the Darjeeling teas. So we've tried to take different elements from that, so this whole greenery and the balance. The symbol of Kerala is the coconut tree. Kerala comes from the word Kerala, which means coconut tree. So we've tried to take textures from our own environment. And just to give you some images of the facility, so that's the lobby, which has all these textures and colors and the light that I mentioned. Those are the bed mix that I had mentioned to you. So we actually have we've tried to sort of make each of the patient rooms sort of facing the water. So every single room that's there, you will be facing the river. When I was talking about technology, like for the nurses and things, we have included things like Archive, which is talking about where technology helps us sort of take in all the data of the patients and create the patient chart. So we try to see how we can reduce the administrative time that is spent by nurses, which in turn will mean that they can focus more on the patient care aspect. This is the COE term. So like I said, all the center of excellence, these are connected to the main hospital. So you have this wonderful design, which like we said earlier, at the end, all you have to think about is how is it going to serve the people who are there at the end. So this helps you connect. So any requirement, you can go into the main hospital, but otherwise they are like isolated. So like the main elements, like I mentioned, you have the Aster City Hospital, you have the 9 centers of excellence, and you have the clinical support centers. One item that I'd like to touch upon on the emergency center. We're the first ones in Kerala that will have a water mobile taxi, so that's mainly because we have the river, so we have the emergency care on water taxis. We also have obviously the normal mobile ICUs as well as a helipad. But as a first response for any critical cases, we also have clinicians going on motorcycles. Now that's mainly to cater to the congestion and the traffic requirements of the city we are in. So we actually commissioned in February. We have already sort of done the first robotic surgery. We've got the Da Vinci system, and we did a urology case, CA prostate, a couple of months back. We've also got the pharmacy robot, which helps in reducing your medication errors. We've got the pneumatic system and the e-prescriptions, which make sure that they can be connected across to the whole hospital. It's a highly loaded environment, of course. It is probably the most loaded in India right now. You've got your 3 Tesla MRI, you've got your 256 slice CT, you've got linear accelerator, you've got your LINAC, you've got your CyberKnife. So there are no compromises made on as far as investment in technology is concerned. It is probably the most loaded, like I said, at this point in time. But the main thing that really sets us apart would be, again, the doctor teams and the sort of service levels that we are offering there. India itself sort of is a provider for the largest number of medical graduates every year. We sort of, into the supply chain of doctors, there are probably around 50,000 doctors that come into the pipeline every year. In Kerala specifically, there are a large number of doctors that are working abroad as well as nurses. So this iconic sort of project has really resulted in us being able to really encourage a lot of our doctors and our clinical staff come back, where they've gone abroad to the US or the UK to come back. They keep saying, okay, you're giving a wonderful facility, I'm closer to home, so that's a great motivation for a lot of people. These are some of the things that I've already mentioned, like the cath lab that we've got, and I mean, we can talk about this later. So just to end really, we say, I mean, why Kerala? Why medical cities? Kerala is a very interesting state. It is my home state. We are the only state in India which has 100% literacy. We're the only state in India which has a reverse sex ratios. We have more women than men here. And because of that, you see very interesting other ratios, such as much lower maternal morbidity and infant mortality rates. And I think that has mainly to do with the sort of women's empowerment that's there. So you're really talking about a world-class, and so the physical quality life index, when you look at it in Kerala, is actually quite high. So even though the GDP per capita is very low, the people are still able to have a fairly good happiness index or other life indexes that you're talking about. So it's really about bringing a true world-class facility and having that at sort of a wonderful, beautiful place. You do really want to have that quality of care and the service levels. Another reason why we are able to make the cost much lower being in Kerala is because it's a tier 2 city. So you're not talking about going to Mumbai or Delhi, where you don't have to deal with the congestion or the sort of pollution that is there. So you're in a much more therapeutic environment that you're in, and then you have this quality that is uncompromised as well. So as an organization and as an institution, we really envision it to be one of the top 10 healthcare destinations in the world. And I think that is the strategic thing that most of us talk about when we talk about medical city. We really do want to be creating something that is unique, world class, and really will require that concentration or specialization to give something back to society. Thank you so much.
The question and answer session, again, we have 2 questions split up. If you would like to ask these questions now, or you will take it later. Yes, please.
Sure. Dr. Sultan, formerly CEO in UAE. Very, very interesting presentation. In fact, I say it's fascinating. It's a marvellous concept. There was just one point I wanted to pick up on, and that was the numbers of doctors and nurses that have left Korea to go to various other locations, UK, North America, and of course here in the Gulf itself. I think people will want to return to family roots and the land of heritage and so forth, but in terms of, you're obviously looking at the cost consciousness of what you're doing as a total operation. Would there be enough economic encouragement to get the reverse brain drain in practice, do you think?
You're right. I mean, it can't be that every single doctor of yours is going to come back from the US or UK, because that way it will not make economic sense for the institution, because you can't match sort of the salaries that they are giving for your entire departments as such. But I think that balance is critical to maintain, and there are some who have who are doing it more at a retirement stage, where they have sort of want to come back and sort of contribute, like I said earlier. So it wouldn't make sense for us to really try and pull back all the experts everywhere, because it wouldn't make financial sense. But to some extent, we do have to attract that sort of people, and accordingly, models have been built.
Our next session is going to be about